Good morning and welcome to the Leukemia Foundation webinar, Coping Together, the Emotional Side Effects of Blood Cancer on Relationships. It's a pleasure to welcome our guest speakers, Sharon McIntyre, who will be sharing her personal story with us, and Dr. Charlotte Tottman, clinical psycho-oncologist. Before we begin, I would like to acknowledge the traditional custodians of the lands on which we're all coming from today, and pay my respects to elders past and present. As we come together to share knowledge and experiences, let us reflect on the importance of honouring and preserving the rich cultural heritage and learnings of Aboriginal and Torres Strait Islander people. Just a couple of housekeeping items before we begin. This session is being recorded. For the best experience, we recommend that you set your screen to speaker view. Please add any questions or comments into the chat, which you'll find in your taskbar. And we will look to cover the questions that come through that chat in addition to our pre-submitted questions during the Q&A, which we will hold at the end of the session. So a blood cancer diagnosis can have a profound impact, not only on your physical health, but also on your emotional well-being and on the relationships that matter most. After the initial shock of diagnosis or treatment, the process of adjustment continues long after. Yet while you may be navigating uncertainty, fatigue, or fear of recurrence, the world around you often expects life to simply return to normal. This gap between what others see and what you feel inside can be really difficult to explain and even harder to manage with those that are close to you. On this World Mental Health Day, we're taking time to focus on the emotional side effects of blood cancer and how they shape our relationships. So today we'll be focusing on the common psychological responses to living with blood cancer, managing the adjustment between before and after diagnosis, the impact on relationships and communication, strategies to support you and those who matter most to you, and how to get help. So to start, it gives me great pleasure to introduce Sharon McIntyre. Sharon was born and lives in Brisbane. As a child in primary school, she experienced frequent headaches and nosebleeds. At the age of 18, Sharon was unexpectedly diagnosed with 2 different types of myeloproliferative disorders. Sharon has lived with the emotional and physical rollercoaster of a blood cancer diagnosis through all ages and stages of life, including study, work, marriage, pregnancy, and parenting. She shares some of her challenges and the impact it has had on her relationships with us today. Thanks, Sharon, over to you.
Hi, everyone. Thanks for this opportunity. So basically, I was diagnosed at 18. So my last couple of years of high school, I was having really bad symptoms and had to repeat. So usually this diagnosis is for people 60, 70, 80 years old. So when I was 18, they didn't really know what to do with me because the effects of oral chemotherapy, usually old age took over before that was a thing, but at 18 years old, they didn't know what to do with me. So the phases and stages of my life have been quite difficult because as a child, I remember my mum constantly dragging me to the Royal Children's Hospital or different hospitals or doctors. I would have fevers, be underweight, nosebleeds, and one doctor just said, oh, well, her hair's really long, cut it off. It's probably taking all her nutrients. So there was a lot of, even though my platelets back then were in the 700s, which is over the normal, they didn't they didn't think, because I was so young, to look at a bone marrow malignancy or a MPN. So yeah, it affected my whole life. The phases, as a teenager when I was diagnosed, I kind of pulled back. I felt like I wasn't normal, and I just pulled back socially in case I got one of these pain flares. So I'd go funny down one side, couldn't see, couldn't walk. So I just stopped going to things. Study and job was really hard with all the fatigue. Like I was constantly, wanting to lie down. And I remember my first boyfriend at the time saying, you're going to sleep your life away. And I thought, I just need to rest. My first job, it was really hard to do a full-time job. So I've been part-time for the last 23 years. And dating was very hard too, because I was not able to have contraception because that would clot your blood. I was not able to smoke like a normal teenager would because that would clot your blood. Marriage was difficult because they told me I probably wouldn't be able to have children. I did fall pregnant, so that was a happy thing at the GP, but then I was told by my hematologist I'd been on oral chemo for 8 weeks, so I had to terminate that pregnancy. So that made that difficult, and relationships around that difficult. Also, before marriage, it was hard to sort of open up about what my cancer diagnosis meant for having a family and things like that. The same with dating. I always felt like something was wrong with me, so I would hold back. Pregnancy was difficult. I had to go to the high risk clinic. I had blood tests every 2 weeks, ultrasounds every 2 weeks. My third child, I had an amniocentesis, and that was difficult on everyone psychologically because they thought she would have something wrong with her due to my blood being funny and tests coming back wrong. A post separation from my first husband was difficult too, dealing with two young kids, trying to get them to kindy and school, and then me to work, and dealing with all the lawyers and the papers and family courts. And I just didn't have the strength and energy. I actually dropped down to 38 kilos, and that's when my blood cancer changed from ET&PB to myelofibrosis, which was a harder diagnosis to live with, more symptoms, night sweats, insomnia, nausea, fatigue. Yeah, some of my relationships with my teenagers have been strained because they say things like, why can't you do things that like other mums can? Like, why can't you come shopping all day with me for a formal dress? And things I've learned now that I could have put in place back then is like, oh, well, shopping centres do have like a wheelchair thing. So I could have got her to just push me around instead of getting so exhausted after 3 shops. Other things, like with my husband, it's just been hard because I don't sleep well and he snores really loudly. It's impacted our relationship that way, and we've had to sleep in separate rooms for a very long time, which has meant our connection, we kind of feel like ships in the night almost. Yeah, it's hard with my littlest daughter. She's 11, and sometimes just her wanting to play or to swim, and to try and communicate that mummy's having a pain flare day is difficult. I remember one time when my oldest were toddlers, I literally had to take 2 endones, put my 2-year-old downstairs by herself and my baby in the cot with 2 bottles, and just go to bed for the whole day. So she was unsupervised for a whole day. So yeah, some of the feelings too are like feeling like a fraud because you get called out. Like, I was sitting in the disabled seat on the bus and an old lady just yelled at me for sitting there, and I said, I'm sorry, I've got a blood cancer. And you know, so yeah, you feel like you're constantly having to explain yourself to people, but then sometimes it doesn't quite get through. So I'm constantly sick with respiratory illness, but then friends will say, oh my God, you're sick again. And I'll say, yeah, this is a non-curable blood cancer. It's like not one where I can ring a bell at some stage after something's cut out, not taking away from anything, any of those, but it's a lifelong thing unless there's a match in a stem cell transplant. So dealing with that has caused me a lot of anxiety, PTSD from other symptoms of my children being bullied and not being able to fully deal with and cope with that, as well as my blood cancer. There's been a lot of emotional stress that I think having an MPN so young has given me this journey. Now I don't put my head in the sand as much as I did as a teenager. I advocate. I try and I'm an advocate for the MPNAA, and I try to speak wherever there's an opportunity to. I try to research different trials, and I want to share what I've found as my successes as being diagnosed young to help other people that are diagnosed young. And hopefully that can, avoid the feelings of sort of isolation or feelings I used to get as a fraud, like, people can't see this, but I know this is happening inside me. So dealing with things like that, the constant headaches, the constant fevers, like, at work I would be sort of yawning or tired on my desk, and I could see other people sort of looking at me like, why is she always yawning? So it's, yeah, some of it might be sensitivities, but other things, I know I can't do a full-time job. I just don't have the capacity to do that. So yeah, it's been really hard. I was ashamed of it at first, but now I advocate for it, and I try and, work part-time. That's the only way I can work. It's hard with traveling because I can't get travel insurance unless, I pay an exorbitant amount of money. A lot of travel, I try about 5, 6, 7 different travel insurance places before I finally find one that will cover me. Yeah, it's just the different hats of going from, the invisible disability to mum to work to, friend. I know that I cannot go out with my friends anymore to like an enclosed type 70s, 80s, 90s disco, because I end up in emergency and they all end up fine. But if it's something outdoors, I can do it. So I know my limits now. Plane flights, I generally get sick and they have an ambulance waiting at the end if it's a long haul flight. So it's just a lot of juggling and making things work. I think that's it from me.
Oh, thanks so much, Sharon. You really illustrate how your diagnosis has pervaded every aspect of your life, from relationships to work to study. But love how you have taken some of that experience and being able to put it to good use in terms of your advocacy work. So we really thank you for that and for being with us here today. I'm sure there are a lot of people in the audience who can really relate to what you've shared with us today.
No worries. Happy to help.
Thanks, Sharon. I'd like to introduce our second guest speaker. Dr. Charlotte Tottman is a clinical psycho-oncologist. She consults privately, providing psychological treatment for cancer-related distress. Charlotte works with cancer patients, their family members, and carers at all stages of the cancer experience. Charlotte works closely with the Breast Cancer Network of Australia, is an editor for the Cancer Council of Australia, and has strong links with the McGrath Foundation, Canteen, Ovarian Cancer Australia, and of course, the Leukemia Foundation. Thanks, Charlotte. Welcome you back again.
Thanks so much, Linda. Just getting my slides up. Hopefully that's worked. Okay, all good. Lovely to be here again. This has become an annual pilgrimage for me to the Leukemia Foundation, and it's something that I really enjoy. I really rate the Leukemia Foundation and the work that they do. So it's my great privilege to join you today. And I just want to, yes, endorse, I think what's coming through on the chat, and Linda and Jen's thanks to Sharon. That was a really comprehensive portrayal of the sort of impact that a blood cancer can have, because I think that long lived experience is more prevalent in a blood cancer setting than, say, in a tumour cancer. It certainly can happen in a tumour cancer setting where people are living with metastatic disease, but I think it's more common in a blood cancer setting. And I think that experience of the change of stages of life and how that changes the experience and how that bleeds out into relationships is probably something that a lot of people who are joining us today can really relate to. And one of the things that really stood out to me when Sharon was talking was something I say in therapy a lot, which is people taking information through their eyes. And so even if they know intellectually that you're living with a blood cancer, or that you have been through blood cancer treatment and living with the fear or the risk of recurrence, if they see you kind of looking more or less okay, they make the assumption that you are more or less okay, and that they often don't make room for the very significant challenges that you face every day and the enormous adjustments that you have to make. So there's that. All right, I'm going to talk to you today from 3 perspectives. As Linda said, I'm a psycho-oncologist, which is just sexy language for being a clinical psychologist who specialises in cancer-related distress. And I'm talking to you from 3 perspectives: from the training and research base about psycho-oncology, from my clinical practice. All the work that I do is in the cancer-related distress space. So I talk about cancer all day, every day. And from my lived experience. I don't have a lived experience of blood cancer, but I was diagnosed many years after starting to work in this space with breast cancer in 2018. And also my parents died of bowel and ovarian cancer in my 20s, and all of my grandparents had cancer. So I kind of get the whole cancer space. I'm going to talk to you about the impact of having a blood cancer on relationships. And as you can see on that slide, the left-hand part is kind of just depicting, maybe an intimate relationship of any type, but also on the right-hand side of the slide is more like the extended family or the family unit or the friends and colleagues that we might have in our social network, and how a blood cancer diagnosis and treatment can affect all of those types of relationships. And just a little bit more on relationships and social networks, which is how we describe relationship systems in psychology. Sometimes it can be helpful to think of them as a series of concentric circles. So you can see this slide, there's a little person in the middle, and that's like the patient or the person who might have had or has blood cancer. And then their social network can be described as a series of circles. And so the first circle might be your most intimate relationships, perhaps your partner and your children. And then the next circle might be your family of origin, so your siblings and your parents, and maybe a very close one to one or two very close friends. And then the next circle might be extended family and some other friends, and so on and so forth. And sometimes just thinking about it in those terms can help make us make sense of perhaps why we are responding or behaving in a certain way with people in our social network, and why they might be responding in a certain way as well, if we can kind of position them in that set of circles. And sometimes I get people to think about them as kind of like your team A, your team B, and your team C. So your team A is your closest people with whom you share just about all of your thoughts and feelings, and then team B a bit less, and team C a bit less again, and so on and so forth. In psychology, we often talk about relationships using a particular theory or model called systems theory. And the picture on that slide is designed to illustrate the fact that it's complicated. And probably everybody listening or watching today understands that even well away from blood cancer, relationships are just complicated. They really just are. And I think probably all of us have had some points in our lives where we've experienced that complexity. And then I think what happens in a cancer setting is that complexity can be fired up even further. And because we haven't done it before, we don't necessarily understand that that's what happens, and we don't really know how to respond to that. So the overarching principle that I'm just wanting to get across at the outset of this webinar is that relationships are complicated. They're more complicated in a cancer setting. And so if it feels like you're not really in control of things, or you don't really understand why things are happening the way that they are, even why you're responding the way that you might be, that's because it's complicated. Systems theory is essentially about not viewing relationships in isolation, but viewing them more like a set of interconnected systems. And so it's like if there's an effect or something happens in one relationship, so say in my relationship with my husband, whatever happens in that relationship is likely to ripple out into other parts of our lives. So if he makes me grumpy, I'm not likely to just be grumpy with him. I might be grumpy for the rest of the day with everyone I meet. And so that ripples out into all of our other relationships. And again, this explains why it's so complicated and why it's therefore hard to control. Relationships broadly are about action and reaction. So a bit like tennis, if I hit the ball down the other end of the court, depending how I hit that ball will have an effect on how that ball is returned. And so it's kind of like action and reaction. And just like a tennis game, relationships are never 100-0. So if things are going well in a relationship or things are going not so well in a relationship, it's never all one person's fault. Even if, I'd qualify that except to say in an abusive relationship, we might be able to say that it's all one person's fault, but in functional relationships, everybody's making a contribution. And sometimes that's important to recognise if you're feeling a bit frustrated or a bit disappointed. You can absolutely feel those feelings, but sometimes it's helpful to reflect on, okay, well, what's my contribution to this situation been? And the last point on this slide is about the fact that, as I highlighted before, once you're in a dynamic, and relationships are dynamic, you aren't in control of what happens. The only bit that you can control in a relationship is your bit. What you do, what you think, how you behave, and you can hope, you can want, you can negotiate, you can try and influence, but you can't control what anybody else does. And that's a really hard thing sometimes to come to grips with. So today, in the context of all of that relationship stuff, I'm going to talk to you about this long list of things. So surprises and disappointments, a thing called emotional isolation, FCR, which stands for fear of cancer recurrence, and FDP, which stands for fear of disease progression, which are similar but different. Post-treatment adjustment, which is what happens in the period after hospital-based treatment ends. The snow globe effect, which is about a perspective shift that just about everybody seems to have. Sexuality and intimacy, which I could talk about for a whole webinar in and of itself, but I won't today. Dual relationships, which is where you suddenly come to understand that you've got not just one relationship happening in a household, but you might have more than one. Carer burden, which is the effect of becoming a carer on the carer. And the sandwich generation, which is about the fact that a lot of people, when they're diagnosed with a blood cancer, might be at a stage of life where they might have children at one end of the spectrum and maybe aging parents at the other. And so they're kind of the middle of the sandwich. And the fact that all of those caring and relationship responsibilities don't just vanish just because you have a cancer diagnosis. So that's what we're going to cover today. It's a lot of information. I'm going to go at a fairly fast clip, but it is being recorded, so you can go back and watch it again if you need to. Lots of questions can be answered at the end of all of this. So surprises and disappointments is one of the many universal experiences that I see in my work. I don't think I've met a client who hasn't been on some level surprised, on other days disappointed by some of the things that they've had happen in their social networks. One of the weird things about expectations is that we all, and I heard a very wise psychologist say this once, we all live with expectations without realising that we have them. And the clue that we have the expectations is when we feel surprise or disappointment when they're not met. And it's like, because it's not like before a blood cancer, you sit around thinking, oh, when I get blood cancer, I think this is what I'm going to expect of my family members. Those thoughts don't happen. But it's when you are in that situation and you find that maybe some people just really let you down. Sometimes people disappear. Sometimes people just shock you in ways that you just cannot have fathomed. And you find that shock to be the clue that there was, in fact, an expectation. And maybe that expectation is based on the type of relationship, like maybe it's, it's your husband, or maybe it's a sibling or a really, really long-standing friend. And so there's this expectation that, well, according to the rules, according to what we know about families and maybe the Disney model of relationships, that those people will just always be there for me. But it unfortunately doesn't always pan out that way. So I have had so many instances in my consulting room of people discussing epic fails where people are really, really, really disappointed by a friend or a family member. And sometimes it's in a very big way where they disappear or they let them down comprehensively. And sometimes we have, well, not even sometimes, happily, quite often, we have what I call gold medal standouts. So we have examples of where people just step up in ways that no one ever believed that they could or would. And these things have happened to me in my own cancer experience. We were certainly really let down. And conversely, I have some people in my life, even now, 7 years down the track, who just check in with me every so often in ways that maybe some other people don't. And it's just a reminder that you can't make assumptions about how this is going to play out. Sometimes they're big epic fails, and sometimes it's much smaller than that. A lot of people struggle with the fact that there's this whole positive pressure in the cancer space where a lot of well-meaning loved ones, family members and friends will kind of use language around, you know, just be strong or you'll be fine, and staying positive is just going to make it all okay. And if you think happy thoughts, that'll make it, you know, that'll make it great, and you look amazing. And I think while on some level we understand that sometimes those positive comments or that positive pressure might be coming from a good place, it can feel very clumsy and clunky, and people don't know how to respond to it because they don't necessarily want to be unkind, but it can really make them feel like the people around them do not understand what they're going through. The other thing that people talk about a lot is not wanting to feel pitied. Pity is one of those things that I haven't met someone who likes pity. And I think that sometimes there can be genuine compassion, but the way it's delivered, it might feel like pity. And sometimes there is in fact pity. And I think the way that that plays out in relationships is that people perhaps withhold information and they don't declare their vulnerability, because it's like, I don't want to tell you that I'm struggling because I don't want you to pity me. I don't need that. I need empathy. I need understanding. I need you to stand by me and sit with me in my distress. I don't want you to try and fix it. I don't want you to tell me just to think on the bright side. I actually want you to just for me to be able to be real about this with you. And unfortunately, we live in a world where not everybody is capable of providing that empathy. And so sometimes in a blood cancer setting, one of the things that's beholden on us is to figure out where those emotional needs can best be met, and to be selective about spending time with those people, because if we keep going to the well and the well is dry, then we're sort of like setting ourselves up for disappointment. So one of the things that I learned through my cancer experience was that there were people who were going to meet those emotional needs for me, and there were definitely people who weren't, and that I got selective about where I spent my time and who I was prepared to be vulnerable with. It would be wonderful if mind reading was a thing. I think all of us in relationships have probably had the feeling of like, you know, it's that bleeding obvious, you know, why can't you just see what I'm going through? Why can't you understand what I'm going through? But it isn't a thing. And so if, again, we expect that people around us are capable of reading our minds and understanding the huge emotional and physical experience that we're navigating, then we are probably going to only be disappointed. The antidote for expecting that mind reading's going on is communication, and that can feel actually quite burdensome, and it can build feelings of resentment, because when you're the patient and you're trying to navigate all of this heavy physical and psychological stuff, it can feel quite unfair that you then have to be the one to do the relationship heavy lifting. But again, the reality and my work has taught me that often if the person who's feeling disappointed or isolated, if they don't articulate that, then unfortunately things often don't change. On that subject of communication, I like to sometimes just point out the way that interpersonal interactions work and what they're made up of. So we can think about interpersonal interactions, which is like the communication that we might have with our loved ones or our friends and family members, as having 4 parts. So there's tone, volume, content, and gesture. And usually in my consulting room, I say to people, which of those 4 do you think causes the most problems? So you can all just have a little think about that. And then I'll tell you the answer is tone. You can say the same words about 100 different ways and have about 100 different meanings depending on the tone that you use. So sometimes understanding that if you're trying to convey a particular message and you're sort of struggling to maybe make your point, think about the tone that you're using. And I won't demonstrate this now because it will not work in a webinar, but one of the things that I often suggest is that if you're really struggling to get a point across, that you start to whisper. Now, whispering is a very funny thing to do because as humans, we mimic one another. If you start whispering, you'll discover that other people in the room will start whispering. And the other thing it will do is it will make people laugh. And that's a very good diffuser. It's a very good antidote for tension. And it can actually bring everyone back to sort of like a grounding position to start again. So leading on from surprises and disappointments, we come to emotional isolation, which is best summed up as the feeling that they just don't get it. And again, this is one of those universal experiences. I haven't met anyone who's been through a cancer experience who at some point doesn't say these words. They just don't get it. And I think, unfortunately, what we come to understand is that the only way someone can really understand what it's like to have a blood cancer diagnosis, treatment, and aftermath and live with that fear of recurrence or fear of disease progression is for them to have had that experience themselves. And of course, as a human being, I think most of us would say, well, I don't want my husband or my friend or my child or my brother or my sister to have to get cancer to understand what it is I'm going through. But it can mean that we spend a lot of time feeling emotionally isolated. Emotional isolation is a bit different to actual isolation. And in some respects, actual isolation, I know this might sound weird, is kind of easier, because if you're on a desert island and there's no one there and you're feeling a bit isolated, well, it makes sense because there's no one there. So of course you'd feel isolated. But if you're surrounded by people and you intellectually know that those people love you and care about you and you still feel isolated, that feels quite confusing, because it's like, why can't I get these needs met? Why can't they get what I'm going through? There's a model that I use to explain emotional isolation. So it starts in the top right corner of this slide. This is where people feel emotionally vulnerable. And so their brain or their radar is up and on to seek emotional support from others. And when they fail to locate or receive emotional support, they emotionally withdraw, which is very reasonable because they don't feel safe. They don't feel like they've got what they needed. But unfortunately, that leaves them feeling even more emotionally isolated. Now, people say to me when I show them this slide, they say to me, what? So does that mean I'm meant to step back into that space? I'm meant to make myself emotionally vulnerable all over again to the people who didn't kind of show up for me the first time? And my answer to that is no, we don't want to do that. That's not going to work. But what we do want to do is we want to find empathy. So we want to seek out empathy where we can. And that's not always easy. It's not automatic. And it's not like there's a queue of people with empathy just like waiting outside your front door. But it is about taking opportunities to connect with people who might have a similar lived experience or might have parts of their life that feel like they can empathise with what you're going through. And Leukemia Foundation is a really good example of where to find empathy. On to fear of cancer recurrence and fear of disease progression. Again, universal experiences. I have not met a client who has not at some point commented or talked about their fear of cancer recurrence or disease progression. So just to highlight what they are, fear of cancer recurrence is the fear that the cancer may come back. Fear of disease progression is the fear that the cancer may progress further. And if it does, that it may threaten the quality and quantity of life. So these are big, fat fears. They're really, really like visceral fears. And it's probably the one thing that from my own cancer experience that I reflect on and think, you know, in all my work and all my training, that's the one thing I didn't fully understand until I came to have to live with it. And I live with fear of cancer recurrence every day. That's just a part of my life now. From the research studies about fear of cancer recurrence and disease progression, the stats tell us that between 70 and 99% of cancer survivors have experienced some level of this. So these are huge stats. And what that tells us is it's normal. It's not weird. It's not unusual. And it also means that it persists. I have lots of oncologists, hematologists, surgeons say to me, Charlotte, can we just get rid of fear of cancer recurrence? And I'm like, yeah, good luck with that. We don't get to get rid of it because it's part of your internal burglar alarm. It's part of your safety system. What do you do if you disable the burglar alarm? Well, the risk is that the burglars get in. So part of the fear of recurrence and disease progression is about an appropriate, if you like, a Goldilocks level of surveillance, of paying attention to how you feel, to any symptoms or side effects. We don't want to switch that off because they're the sorts of things that get you to go back and check, is everything okay? Your internal burglar alarm is what gets you to step onto the sidewalk if there's a semi-trailer coming down down the road at you. You know, it's an important part of your survival system. But when it's dialed up too high, it can feel debilitating. And if we find ourselves having more scans, more doctor appointments, more debilitating fear symptoms, then it's worth talking to a professional like me about that sort of thing. But learning to live with fear of recurrence is a whole thing in and of itself. A lot of the work that I do in my clinic is about making room for fear of recurrence. It's kind of like an uninvited dinner guest, sort of like, well, you weren't invited, but you're here now, so you may as well pull up a chair and let me get to know you. And starting to understand what your triggers are and how you respond to them and how quickly you recover from those triggers is part of making room for it. It's all about living with uncertainty, and that's what the aftermath of a diagnosis and treatment brings, is just that awareness that it doesn't matter how good we might have responded to treatment, that there's no rolled gold ironclad guarantee that everything's going to be okay now. It's like we live with that shadow, we live with that sort of guillotine hanging out there in our mind's eye that, you know, at some point things could turn, and if they do, it won't be good. And living with uncertainty is not something humans are set up for. You know, we like predictability, we like a sense of order and an organisation, and the reason for that is that when we have all of that predictability and order and stability, it makes us feel safe. It brings our anxiety down. And so for us, uncertainty equals it's not safe and it feels anxiety provoking. That's why none of us did very well through the COVID experience, because we were all doing something we'd never done before, and we didn't know how long it was going to last and how it was going to unfold and what it was going to mean for all of us and our families. And it's like that living with and after blood cancer, just like COVID was, except for the rest of your life. These are the triggers, and the number of these triggers explains why fear of cancer recurrence and disease progression doesn't go away, because when there are this many triggers and you get that these triggers happen, you know, sort of every few weeks, every year of your life, there's no chance for it to go away. So in no particular order, the triggers include diagnosis. So as soon as we get diagnosed and we understand there's a treatment protocol, we start worrying about whether it's going to work, whether the cancer is going to come back or progress. Medical reviews, even though they're scheduled and they might not indicate any sort of nastiness, just the fact that we have to go back into that environment, be that patient with that doctor, can be very triggering. Cancer anniversary, so sometimes that's diagnosis date, sometimes it's the date of a transplant, sometimes it's the end of treatment, and of course these come around every year. The diagnosis or death of a loved one, family member, of a friend with cancer, but sometimes not even with cancer, just that vulnerability, mortality thing, that reminder that, you know, life is fragile and that tomorrow is promised to no one. Media stories, sometimes that's about someone that we might know being diagnosed, like when Magda was diagnosed. Sometimes it's about research, sometimes it's good stories. I put into Google one day, how many cancer stories are there in one day on Google? 68,000. That's what it told me. 68,000 in one day. So, you know, you can't escape this stuff. Physical symptoms, this is the biggest one of these triggers. So if it's a symptom that resonates with you because it feels like that's the sort of symptom I had around diagnosis, that's going to be very scary. But it's not limited to that. I can get a headache and within a nanosecond, I'm convinced I've got brain mets, and my symptoms weren't in my brain when I was diagnosed. And then I challenge myself to come up with some other explanations for why I might have a headache, like I might be dehydrated or stressed. And then I do a little probability analysis, and then I monitor. And if I still had a headache, you know, in a few days, and if the headache wasn't going away with some Panadol or some rest, then I might get it investigated. So it's not about denying symptoms or avoiding getting things checked out, but it's also about engaging your rational mind when those things pop up. And life planning and decision making is a trigger, because when we start to think about the future, sometimes we start to feel or wonder or worry about whether that future will be for us. The other thing that, and how this plays out in relationships, is because fear of cancer recurrence and disease progression isn't limited to the patient. Loved ones also experience fear of cancer recurrence and disease progression. And the thing that is tricky in this space is that the perspective is different, because the loved one is very reasonably thinking about it from the perspective of like being the observer or the carer, and also thinking about, well, if something happens to my partner, to my loved one, well, I'm thinking about, yes, how that's going to affect them, but I'm also thinking about how that's going to affect me, how that's going to affect my life, my family, our future. And so it is a difference of perspective. And everybody responds to information differently. So some people will be more worried and some people will be more avoidant. And it's very, very rare that you get a nice mapping on of identical responses to the same degree of information in the cancer space. You have some people who'll be like, and this actually happened in my clinic yesterday. A woman had an excellent response to treatment, but she's still living with a very, very serious advanced cancer situation. And so she's very realistic and she's going, this is great news, but I'm still in a very serious situation. Her husband is thinking that this is a miracle. This is great. So it's all over. It's fantastic. I've got her back. She's not going anywhere. And so they are looking at it from very different perspectives. Now, it's very early days. They've only just got the news of this good response to treatment. But even within all of that, she's feeling a little bit isolated because she understands the reality of the situation and he's not quite there with her. And so that difference in perspective and that difference in fear can set up, or inflame a disconnect in a relationship. So the next bit I'm going to talk about is post-treatment adjustment. And this slide is just a nice little depiction of the timeline of a cancer experience. Now, it obviously is a simplistic version of things, and lots of you will have had experiences that don't fit this particular timeline. But broadly speaking, what it highlights is that the front end of a cancer diagnosis of a cancer experience is the diagnosis. And then you usually go straight into, for a lot of people, not everyone, you go into hospital-based treatment for months to years, and then that comes to an end, and that's when this phenomenon called post-treatment adjustment starts. And this is not talked about much, but post-treatment adjustment lasts at least 2 years and often a lot longer. I think for me it was probably at least 4 years before I felt like I had any idea who I was after cancer. So this is not something that's highlighted at the beginning of a cancer experience, and that's very understandable. I completely understand why, when you are in the medical setting and the focus is on diagnosis and getting people into treatment protocols, no one's talking about what happens after treatment's finished. That's like, worry about that later. But post-treatment adjustment and the end of hospital-based treatment is when I get my most referrals. It's when I see people mostly for the first time, because they've often survived treatment reasonably well and they've navigated through the horror and then are a bit surprised to fall in a bit of psychological hole when suddenly that all stops. And it's at this time that we start to rehabilitate psychologically and physically, and we also start to reclaim life. So things like work, caring obligations, relationships. And because we aren't the same person as we used to be, it frequently does not go very well. So as I was just saying, post-treatment adjustment, at least 2 years from the end of hospital-based treatment, not often highlighted earlier. It involves physical and psychological recovery, and a lot about navigating this space more helpfully is about recalibrating expectations. I'll just flick you through some slides that explain this in a bit more detail. So imagine that's your life and that's the moment of your diagnosis. Before diagnosis, you had what we call your pre-cancer life, and after diagnosis, you have your post-cancer life. Your pre-cancer life in your brain would often be thought of as your normal life, and your post-cancer life is your new normal. In your pre-cancer life, in your normal life, you would have had a bunch of expectations, standards and behaviours that for most of us worked really well. Got us out of bed every day, got stuff done, felt like we were functioning humans. And without realising it, we drag those expectations, standards and behaviours into our post-cancer new normal life. But we fail to take full account of the fact that our cancer treatment has left us different to how we were before. Capacity and stamina in particular are changed and often changed forever. And so when we don't fully account for that change and we hold ourselves to the same expectations as we did before we had cancer, it sets up feelings of failure, disappointment, and frustration. So people say to me, how do you know when I'm struggling in the post-treatment adjustment phase? And I say, well, if you're feeling frustrated with yourself, or you're feeling like a failure, or feeling disappointed at how things are going, that's the clue, because you haven't made an adjustment. You haven't recalibrated your expectations, which brings us to expectation recalibration. Say that when you're drunk. So expectation recalibration is about changing the expectations that you have of yourself, and in doing so, about educating other people around you about what you are now capable of doing. And when people say to me, well, Charlotte, how do you do that? I like to say use maths. Love maths, because maths is kind of straightforward. So you want to think about, if it used to take you 2 hours to do a certain thing, you want to change your expectation and multiply it by 1.5. And so it's going to take you 3 hours now. Or if you used to be able to tolerate sort of standing on the sidelines of a soccer pitch for 30 minutes, you want to take that down by about 2/3. So it used to be 30 minutes I could stand and watch a soccer match. Now I can do that for 20 minutes. So use maths. It's really helpful. It makes it kind of quite straightforward. And then you can convey that to other people. So you can say, okay, I'm giving myself 1.5 times everything, or I'm taking it down to sort of 2/3 in terms of what I can tolerate. The snow globe effect, yet another universal experience. So this is what I use to describe a perspective shift that I see in just about everyone who's been through a cancer experience. So to explain what the snow globe effect is, most of you will probably have seen at a tourist outlet somewhere, a little like snow globes, like a little glass ball that's got fluid inside of it and a bunch of snowflakes, and sometimes like a landscape or an Eiffel Tower or something on the inside. And when you shake it up, all of the snowflakes swirl around. So imagine that a snow globe is your life. A cancer diagnosis shakes up your life. All the little snowflakes inside the globe are your values and priorities. The cancer experience sets them all swirling, and when they settle, none of them lie exactly where they used to. So things have changed. Values and priorities have shifted. Things that used to matter don't matter anymore, and things that didn't matter before often do matter now. There's an increased clarity about what is and isn't important to us, and there's an increased willingness to live life consistent with that clarity. So this is I think it's kind of cool, one of the cool things that comes out of a cancer experience, if you could say that there's anything cool about a cancer experience, in that it kind of gives you an opportunity for a bit of a reset or a bit of a do-over. And for some people, that's small things. You know, it's like saying no to things. It's like maybe doing things a little bit differently, maybe doing some things that they might otherwise not prioritize, like maybe engaging with a new hobby, or stepping away from something that was not really working for them. For some people, it's bigger than that. You know, I've had some people say to me, when I was sitting in the oncology room, when I was diagnosed, I decided, right, we're selling the house. Now, I do say to people, no big decisions in the first year, unless you absolutely have to, is probably not a bad way to go, because sometimes those decisions can be emotionally driven. But it's a really interesting effect that I see in just about everyone. But there's a but. Sometimes there can be cracks in the snow globe. And what this means is that in a relationship context, for most people, when they're diagnosed, they've got a bunch of life decisions they've already made. And often that can be around things like relationships, marriages, kids, mortgages, jobs, commitments, obligations. And if your perspective changes and you decide, do you know what? I think I might like to shake it up a bit, might like to live a slightly different life. Sounds good. And if you live in a cave all by yourself, well, you can change your life because it's not going to affect anybody else. But if you're living in a household or a family with other people, and your decisions, your changes in priority, your shift in perspective is going to affect them, it may not always go well. In my own case, I really kind of wanted to like run away from my life. I wanted to kind of like, you know, have a complete do-over and, you know, stop work, sell the house, do everything. And I said all of this to my husband, who very calmly and graciously sort of was sat there quietly and said, okay. Could we just slow it down? Because he was a bit worried that this might end in tears. So we did slow it down and we didn't burn my life to the ground. We did move to the Adelaide Hills a few years later, and it was one of the best decisions we've ever made. So that was a good thing. But it really highlighted to me that, what seems like kind of a cool thing, that like, oh, I can I can have a reset, I can have a do-over, I can do this life differently. It can go well if everyone in your life is on the same page. But sometimes the new ideas don't fit with the existing framework. And that requires communication. And it requires an acknowledgement that what's going on for the patient does have real implications for the people around them. Sexuality and intimacy, I could talk about this for the whole webinar. We could do a whole nother webinar. And this is a really big topic, and it's probably one of those, I said before we came on screen today, that this is one of the big elephants in the cancer space. It doesn't get enough airtime. Nobody really likes talking about sex, but it is a big thing. If people come into my consulting room and want to talk about sexuality and intimacy, usually what I end up doing is I have a whiteboard in my room. I usually end up writing 3 words in a line on the whiteboard. The first one is sexuality, the second one is intimacy, and the third one is communication. And what I end up highlighting is that you can't have sex without intimacy, and you can't have intimacy without communication. So while we might have come in here to talk about sex, we're going to end up talking about communication, and that you can't improve what's going on in the sex and intimacy space if you don't talk about it. And that's one of the reasons that things don't improve, is because nobody likes talking about sex, and we don't often have much practice about doing it. So it is a really big topic. These are the sorts of things that are factors in that space. So looking around this slide from the top right, there can be practical changes, which is what Sharon was talking about before, where you might be sleeping in separate beds and sleeping in separate bedrooms. And it is very hard to have sex with someone who's sleeping in another bed in another room. I haven't quite worked that out yet. So, that's a very big barrier to intimacy and connectedness. It's also a very important thing to get sleep. And so I'm not going to sit here and say you should not be doing that. But it is about recognising just what a big barrier such a practical change can present. Stressors related to ill health can be things like financial stress or work stress, which come along with something like a blood cancer diagnosis and treatment. Treatment effects, so actual side effects from treatment, which can be really severe, particularly in the fatigue and nausea space. But lots of medications, lots of treatment have much more interesting side effects than that, and none of them are nice. Role changes, which I will talk about in detail in a minute, but if you go from being in an intimate relationship with someone and then they also become your carer, that can be a bit tricky in the intimate space. Function issues, often diagnosis and treatment can mean that things do not work the way that they used to work. And body image concerns. So, treatment and the disease itself can mean that our body image, the way that we appear, the way that we feel, things like weight changes, hair changes, other effects of treatment can mean that we don't feel good about ourselves, we don't have body confidence, and that bleeds right into the sex and intimacy space. And all of that adds up to decreased frequency and satisfaction in sex and intimacy. So again, lots and lots of stuff in this space that can contribute. And the one sort of starting place to make any difference in this space is, in fact, communication. What it means in intimacy and sexuality is that a lot of what we have historically experienced as an automatic arousal and maybe physical experience becomes very manualized. So it goes from being kind of a physiological thing that happens automatically to kind of being a cognitive thing that you have to sort of like talk yourself through. And again, that doesn't sound very sexy. So sometimes recognizing that and understanding that my sex life now isn't the same as it used to, just like the rest of my life is a new normal, my sex life is a new normal too. And that can take some getting used to. I quite often talk about how to navigate this space by using the analogy of learning new dance steps. So for most mature relationships, as a function of repetition in the sex and intimacy space. Most of us have a set of moves, you know, kind of like a set of dance moves. And I reckon, just from my clinical research, I reckon that most of us have maybe about 6 or 8 regular moves. And then for special occasions, we might have another 3 or 4. So maybe most of us might have a repertoire that might go up to 10 or 12. And what happens with cancer is some of those just don't work anymore. And so rather than going, okay, well, we're going to fold up our tent and we're just not going to try, it's about having the courage and having the communication skills to be able to try some new dance steps, learn some new dance steps, and to learn them together. And Rob, that's my husband, we did this. It took us a while. I don't know that our new dance steps are as good as the old ones, but they work. And so it's probably been pretty good for our relationship to have to get into that space and be willing to take some emotional risks together. And that has meant that we have been able to continue having an intimate relationship in the aftermath of cancer. And it's not the same, but it's not nothing. Dual relationships. So this is when you go from having maybe, as you can see on the left-hand side of the screen, the stereotypical kind of intimate or maybe long-term partnership relationship. Might be heterosexual, might be homosexual, doesn't matter. And you go overnight on diagnosis. You go from that to also having the patient-carer relationship within the same dynamic. And that's tricky because for the patient, they've become a patient overnight, and for the partner, they've become a carer overnight. Nobody gets to put in an application for being a carer. They don't get to, like, 3 months out go, oh, quite like to be a carer now. That doesn't happen. They wake up one morning, it's like, oh, right, I'm doing that now. The way that I explain this is sometimes I talk about it'd be really handy if they handed out like white and red hats, and that when you're in your husband, wife, or your partner kind of mode, you're both wearing white hats. And when you're in your patient carer mode, you're both wearing your red hats. But it gets tricky when you haven't got those hats to signal which you're in. So to illustrate this point, I talk about when I was sick, and if Rob said to me, in husband mode, if he said to me, oh, darling, I really love your veal parmigiana. Do you reckon you could maybe do the veal parmigiana for dinner tonight? If I was in wife mode, I'd say, sure, I can do that. But if I was in patient mode, I'd be like, are you kidding me? So he's not to know when he looks at me whether I'm in wife mode or patient mode. The only way he finds out is by taking that risk and asking me to cook the veal parmigiana and then finding out either the easy way or the hard way that I'm in either wife or patient mode. And that is how a lot of dual relationships work. We don't have the white and red hats. We don't know whether you're talking to your partner or you're talking to your patient, or you're talking to your partner or you're talking to your carer. And sometimes just recognizing this and talking about the fact that we now have 2 relationships, and we used to just be partner and partner, and now we are patient and carer, and we need to acknowledge that. And that doesn't fix it, but at least it puts it on the table, and it means that there's language to use about navigating what can be a really tricky space. One of the things that happens as a carer, and we certainly felt this in our household, was that for the carer, their stress load goes up. So, for example, in our house, Rob had to run the household, do all the things that we both had taken care of for years. He had to do that by himself. So the load of tasks on him went up, but also he didn't have me available to him as a resource. So his load went up and his available resources went down, and that meant the net burden on him was significantly higher. And again, this isn't something that we necessarily explicitly highlight. There's a lot of very reasonable attention on the patient when they're diagnosed and going through treatment, and there is very often very little attention placed on the carer and the burden that they might be carrying. And most committed relationships, the carer doesn't want the attention on themselves. They don't want to be they don't want that to be where the focus goes. But nevertheless, what they're going through is significant. This slide highlights the importance of carer self-care. So for those of you who've been on an aeroplane, you will have seen the crew member do the safety demonstration, and they'll say, you know, in the unlikely event of an emergency, this oxygen mask will drop from the cabin above your head. And then they say, before fitting them up, be good if I got this right, fit the mask to yourself before you fit it to anyone else. And the reason they highlight that is that if you pass out, you are not any use to anyone else. And sometimes it's a very simple message like that that we need to remember in the carer space. The carer needs to look after the carer as well as looking after the patient, because if the carer goes down, then there's no one left to care for the patient. And so finding ways for the carer to have time out, to have respite, to have a break, to have social connection, to have sleep is really important. And as I highlighted earlier, the sandwich generation, which is this concept of the person being diagnosed with blood cancer, also having at that time in their life caring responsibilities at both ends of the life spectrum. So maybe children, whether they're little children or adult children, and maybe aging relatives, is a really tricky space to navigate, because those obligations or relationships or loves don't just disappear just because you get a diagnosis and go into treatment. And so sometimes, a little bit like I was saying before about recalibrating expectations, this is about recalibrating what you're able to do in those caring spaces during diagnosis and treatment, and even in your new normal after treatment. So it comes under the heading of boundary setting. Boundary setting is about starting to live life more on your terms. It's about understanding that you can say no to things. There are hard no's, like no, and there are soft no's, like not today, or I can't do all of that, or I could help, but I can't take full responsibility. And understanding that also, whilst we are not socialised around this, and particularly women are not socialised around this, that being able to say no without an apology or a justification or an explanation is actually a completely reasonable thing to do. And so that's no is a sentence. Whereas most of us are socialised around the idea that if I say no, I have to have, you know, chapter and verse to justify why I'm not going to be everything to everyone all of the time. The other thing about boundary setting is that it is frequently a two-step situation, and we don't often think about it as a two-step situation. So boundary setting is like literally building a fence where there wasn't one. You're saying no where you might have said yes your whole life. You might have been everything to everyone right up until you were diagnosed, and now you're trying to actually set some boundaries so that you can recalibrate expectations of yourself, other people can understand that there are limitations, and you can protect your health going forward. So imagine that there is a field, a grassy field, and there's a whole lot of animals who've grazed in that field for years and years and years. And one night, unbeknownst to anyone, the farmer puts up a fence in the middle of the field. And the next morning, when the animals like bump into that fence, do you think that they just bump into it and go, oh, there's a fence, that's all right, I won't mind? No, they go, what is that doing there? That's in the way. That's stopping me getting to that lovely pond and those ducks on the other side. And I always go there every morning to graze. So they try and push the fence down. That's what happens in boundary setting. So you have to be ready for that. You have to be ready for the pushback. So I think about boundary setting as two steps. You got to put in the fence, and then you've got to be ready to hold it firm. So it's like when you say you're invited to do something and you think, no, I just don't have the capacity for that, so I'm going to decline. No, thank you. Not able to do that. And you feel good about that because you're like, no, I've set that boundary. And then 24 hours later, people come back to you and go, oh, we can't do it without you. We've got to have you there. Like you're the person that like is going to make it all the best thing. And because you didn't see that coming, sometimes you wobble and you end up letting the boundary slip. And so it's about understanding that the first part of the boundary setting is usually the easier part because you've got determination and you've planned it and you do it when it suits you. The second part is often catches you off guard, and that's when you've got to be kind of like braced for it and ready to go, nah, I'm going to hold firm to that boundary. So in summary today, we have talked about a lot of things and highlighted the fact that blood cancer impacts thoughts, feelings and behaviours in our relationship with loved ones. And most of all, that it's complicated. We don't always get our emotional needs met. And it's important to recognize that, because, like I said before, if you feel like you're not getting your emotional needs met, that is important, and it's important to do something about that. Declaring vulnerability isn't something that many of us know how to do naturally. We aren't socialized around it. We should be taught this in primary school, but we're not. There's a lot of stuff around being strong, being positive, being stoic in the face of adversity, and actually learning how to declare vulnerability is a really important thing. But in order to do that, we do need to feel like safe, and that can feel hard, particularly if you have been let down in the emotional space. A lot of people struggle to reach out because they feel like an imposter. They feel like other people have got a harder road to hoe. If they feel like when they look at other people's lives, other people are doing it more badly than they are. And so it's like, my stuff doesn't justify or warrant support. In the work that I do, happily, we say that there is quite low pathology in psycho-oncology, which means that while people are struggling very legitimately with things like fear of recurrence and adjustment and anxiety, we don't see a lot of the high level debilitating hospitalizations in the mental health space that we see in other parts of psychology. But that doesn't mean that your struggle isn't valid. If I had my druthers, if I had utopia, it would be that every time someone is diagnosed with any sort of cancer, that they're immediately connected to a mental health professional, and that it's an opt-out situation rather than a try to find your way in situation. Because I think that this is like a tsunami hitting your life, and who knows how to navigate a tsunami without a bit of help. Mental health supports, so broadly empathetic others, and that can be individuals, but it can also be organisations like Leukemia Foundation. Your GP is not a bad proxy as a start for support if they're a good GP, and a therapist, and that can be a psychologist. There aren't very many psycho-oncologists. I wish there were more, but a good therapist can be very helpful in this space. And that takes me to your questions.
Thank you so much, Charlotte, for just an incredibly insightful presentation. So much common sense. I think that's what I've gotten out of that, and I certainly can see that our audience is really related to a lot of the information and the concepts that you've described. So I'm going to hand over to Jen to kick off our Q&A with a combination of the pre-submitted questions and some of the themes that have come through in the chat as well. Thanks, Jen.
Thanks. I'm going to start at the end, Charlotte. I'm going to go back to that bit about connecting with the mental health professional and where to seek that support, because I think a lot of people, if we talk about expectations, have enormous expectations that their haematologist can address all of the needs related to their cancer. Yep. And it's really not possible. And so there's a setup there for disappointment. And we know that you need to explore other ideas and places and professionals and really expand your support network. So I'm going to start with you, Charlotte, about whether you can think of any other ways, and then I'm going to go to Sharon to see what her thoughts are.
Yeah, it's a really good point, Jen. In fact, there was an article written in The Guardian, I think, in the last few days about by an oncologist who writes for them a lot, and she was referencing the fact that she'd spent about 40 minutes with a particular patient thinking she was doing great work and kind of expanding her oncological skills into more the mental health space, only to discover that it hadn't really worked out as well as she thought for the patient. And she was sort of making the point that oncologists should be oncologists, and that mental health experts should be mental health experts. And I think some of that's about skill sets. Some of it's also about time.
Yes.
And that I do know oncologists who have very holistic abilities and who do dedicate more time, but that's a rarity. And I think that it is about being clear about what you expect from your particular health specialist. It's like you don't go to your surgeon for his personality, you go to him for his surgical skills. So yes, some of it's about being discreet and discerning about what am I expecting from my haematologist. If I'm going to them looking for emotional support and a bit of reassurance and hand holding, I might be disappointed, and that might not be because he's a bad person. It might be because my expectations are a little bit off. In terms of accessing mental health support, we know through the pandemic that psychologists are really hard to get into. It's not as bad as it used to be. And certainly there's more access around regional and remote than there used to be, but there's still enormous gaps in what's available regionally and remotely than in metropolitan areas. We are doing telehealth much better than we ever used to, and there are now phone lines that are available from lots of different services. So I would say that things are fractionally better than they used to be, but there's still a huge opportunity in the mental health space generally, and then huger again in the psycho-oncology space. I think if people are noticing that they are feeling, the way I guess that I say to people to tell if you are really in need of some mental health support is when your mental health stuff is bleeding out into other areas of your life and causing a problem. So if you are feeling so low or so anxious that you can't attend to your normal obligations, your normal commitments, your work, your caring, your study for more than a couple of weeks, then that is a really clear sign that you probably need to talk to someone. I know one of the questions that we have in our pre-question list was about how to discern when something's mental health versus when something is maybe treatment side effects. And the truth of the matter is it is very hard. And even if you go and see a psycho-oncologist or a psychologist, for the first few sessions, it might actually be quite tricky to tease that apart and figure out, well, is it depression or is it like treatment side effects or is it both? And frequently it would be both. If you're looking for ways to try and figure out, okay, well, what's what, sometimes things like mood is very important. So if you feel like my mood is incredibly low and I'm terribly sad and terribly low and my thoughts are going to places of despair and kind of like, what's the point? Then that's a pretty clear indication that it's a depressive symptom. It might not be full-blown depression, but it's a depressive symptom. Similarly, if you are able to engage even sometimes in activities that would have typically given you some sense of joy or a good feeling, and if that feeling is still prevalent when you do those activities, that's a good sign. That's a sign that, okay, it might not be depression. It might be more like you're just absolutely hammered with fatigue and nausea and other side effects. But if these sorts of things are sort of percolating for longer than a couple of weeks, it's a good idea, and a GP can do an assessment before you get even close to a psychologist to give you a bit of a clue of like, okay, I think this is something that does need a bit more specialist attention, or maybe we can do a watch and wait and stay in touch for a few more weeks and see how it pans out.
Yeah, so I guess it's trying to match that range of options available to the significance of how those symptoms or is impacting, or as you say, bleeding out into your everyday life, which is such a great phrase because it helps you see how it seeps out into all other things.
And the other thing, I guess, that's worth highlighting too is that in the blood cancer space, people often spend quite a lot of time in hospital, and a lot of the major hospitals will have psycho-oncology team members, and they do similar work to what I do, but it is a little bit different because they are dealing with people who are in hospital. And when you're in hospital, it is very much about dealing with the rigors of blood cancer treatment, which can be punishing, and also with the isolation that often comes with being in hospital for extended times. So it's often about how do we just tolerate, what might be weeks or months of being away from family members, weeks or months of being really, really incapacitated by physical effects of treatment. The work that I do, which is beyond that, is much more about when we're back in the world, when we're reclaiming life, how to navigate that sort of thing. So it's worth understanding that you might be able to access support while you're in hospital, and it can get a little trickier when you are outside in the community.
Yeah, thanks. And I think that's definitely the experience. And Sharon, I'm going to ask you to comment on that, because you've been dealing with this for such a long time at all those different time points. Have you got any hints or even revelations, things that you've discovered now, the old, I wish I knew then what I knew now. Oh, you have to unmute, honey.
Yeah, definitely. And that was great information Charlotte gave. So I've learnt so many things from that. In terms of my heme, the skill set thing is very valid. They're there, for your blood cancer, I suppose. But I wouldn't if you don't feel comfortable, you always have a choice as a patient to get a referral to another heme to see if you click better. But for your sort of emotional needs, your family relationship needs, like I'm going through the sandwich generation at the moment. My youngest is 11 in primary school. My mum, I'm trying to find a nursing home for her, plus make everyone at work happy and everyone everywhere else happy. And it's hard. I feel like the best way I describe it to people is my battery doesn't charge like a normal mobile phone. Like it can be on charge all night, but it's still on like 5%. Whereas, if I didn't have this, it might be up to 100% by the next morning. So this is my limited thing I can deal with. In terms of mood and just like Charlotte said, I always felt, especially diagnosed young before the internet, no one gets it. There's no one like me around. I'm 18. I've got this old person's disease. My heme's telling me I've got a limited life expectancy. What on earth does that mean? And thank goodness, social media hasn't been good for some of my kids' mental health, but for me, I've reached out and found support groups instead of at 18 having my head in the sand and just trying to pretend I was normal. Now I can engage. So I do really miss the Leukemia Foundation MPN coffee and chat, because that was the only way I met someone else with an MPN that had a little baby. So just being able to say, oh my gosh, was your fatigue so bad you can't lift your baby up sometimes? And she was like, yes, So it was just things like that. Sometimes my pain was so bad I couldn't open the baby food jars. Like nobody else sort of got that. And having this cancer that is a chronic, rare, but long-term, non-curable unless you have a stem cell transplant, it's kind of there with you, like your little sort of shadow that's just there for your whole life. And I found it has affected my relationships. It's definitely affected, I think, my husband and I, going from dating and intimacy to, well, now he's the carer and I feel like I'm just, a housemate. So there's a lot of things that mentally have to adjust with, and I've gone to my own separate counselling that's not my heme to try to deal with that. And again, if it's not a good fit, just try another one. And there's a lot of groups out there through the Leukemia Foundation, for me through MPN-AA. I've found giving back helps my mood too. So I always used to do Light the Night. I this year did World's Greatest Shave. It's growing back a bit now. And things like that just sort of will lift my spirit where I can, but also communicating to people that I don't know from day to day if I'm going to have a pain flare or not. So that's what's helped me sometimes, although my mind wants to just be normal all the time.
You've actually touched on a lot of the other questions that people have asked, Sharon, and I think drawing out some of those themes of what younger people with a blood cancer face that are perhaps different to what older people face, in the terms of you're heading into the workforce, you're heading into dating and families, all those different sorts of things. It's not just
like contraception. There wasn't
Yeah.
anything when I was 18 because it would clot my blood even more, and my blood was so sludgy sometimes they couldn't take a blood test. So he was like, no to contraception, no to smoking. Like, you know, yeah, there was.
And that idea that sometimes you have to find your own solutions because sometimes there isn't that information around, as you've rightly pointed out. And I think that low cost, no cost sort of support too, that in between of having nothing to perhaps being able to access someone like Charlotte. So support groups and Facebook pages and disease specific organisations where you can feel seen and heard and understood. It's
That's
already
right.
there, it's built in. Yeah, that's really
Right. And
helpful.
especially with our global kind of community now, like I sometimes get on the New York blood cancer chat, and peer support, I think, is so important.
Yeah, great suggestions. Thank you so much. You've actually answered about 4 questions in one there. So I'm going to flick to one actually that is more about a different kind of relationship. And again, I'll start with Charlotte. And I think, what are some of those unique considerations in that parent-child relationship when the parent has a blood cancer? Because we've talked a lot about partners, but I think we also have to recognise that parent-child relationship and the different needs. Yeah, thanks.
The thing that I see the most in this space is the extraordinary lengths that parents will go to in an effort to keep things normal during diagnosis and treatment and even in the aftermath. And without question, that is coming from that very instinctive, protective love space that we probably mostly all have as parents. But it can mean that it in some respects is a form of not really acknowledging, it's that adjustment piece again, not really acknowledging that this in fact isn't normal. And if we try to keep making it normal, we're expending an awful lot of time and energy into something that, well, A, we can't control, we can't make it be normal, but also that time and energy might be better spent on tolerating treatment, on navigating the experience, on protecting our health going forward. And so I often do encourage parents gently to recalibrate expectations, and that if that means that there's a bit more takeaway or a bit more screen time, or that kids are picked up and dropped off or spend a bit more time with friends and family members during and after treatment, that everyone will be okay, and that the children won't be traumatized by this, and that the legacy will not be damaging to them. The other reason that I think it's quite important to recognise that in fact living through a cancer experience isn't normal is because modelling is very important. And so if we model to children that we have to always maintain this kind of like Disney version of life, then the message that they receive on some level is that there is no space for fear, and there is no space for worry, and there is no space for questions, and there is no space for anything that's not normal. And actually what we want kids to feel is it's like it's okay to be a bit scared, and it's okay to declare that, and it's okay to have a few tears, and it's okay to talk about all of this stuff and to be real about it. This can feel very, very scary because, it is confronting stuff that we don't really want to confront. Nobody really wants to confront all of the realities that come with a diagnosis and treatment. So that would be probably the biggest thing that I see in the parenting space. The other thing would be about when to tell children certain things and what to tell them. I sometimes remind parents of like the developmental stages that children go through, and that children are sort of protected by their brain development. So if you put a whole age range of kids and adults in front of the film Finding Nemo, you would come to understand that everyone takes in different things from that same film based on their brain development. So a 2-year-old is just going to see a whole lot of like bright colours, and a 4-year-old is going to be able to identify a few different fish, and a 6-year-old is going to be able to tell you about their names and personalities, and a teenager is going to be able to talk to you about some of the cool things, and a 25-year-old is going to be able to say, oh, I think there is some political innuendos in there somewhere, and there's the older people are going to be able to say, oh, there's some messages about life and choices and stuff like that in there. So everyone will take different things away from the same thing depending on their brain development. So sometimes parents get very worried about like, oh, my child is not going to be able to process what's going on or process the information, and it's like, well, actually their brain's going to just act as a filter, and it's going to protect them. And as long as you do what you would normally do as a parent, which is behave in an age-appropriate way, it's going to be okay.
I think that age appropriateness is a really valuable one to remember, because kids will reevaluate things at different ages and different levels of understanding in the same way we do as adults at different ages and stages of our lives. So it's a really helpful,
And the other
thing.
thing I would say is that the one thing that I always reinforce with all people dealing with children is you never want to get caught in a lie. So it's okay not to tell the whole truth. It's okay to be sparing with information and to decide what you are and aren't able to or willing to share with them. But you don't ever want to have them find out that you've lied to them, because that will be a breach of trust that will never heal. And that in the context of all of the things that might follow, they will quite rightly feel like, well, if you weren't going to tell me the truth then how can I believe that anything you tell me afterwards is going to be real? So that's a really important thing. And people can get tripped up by that, because in their effort to protect and keep the normal, they'll sometimes do a bit of deception, and that's not a good thing.
Yeah, it pays
And
out down the
Charlotte,
track.
can I just add to that? I think that is wonderful information. Also, for me, being diagnosed at 18, my children were just born into me having a chronic rare cancer. So my little girl, the eldest one, she ended up just thinking everyone's mummy went to hospital once a month and
Yes.
blood tests. That was just what mummies do.
That was
So
normal.
in her mind, she didn't know any other thing. And I may or may not have managed that right, because then when she got to high school, she was talking about something and, oh yeah, my mum has a blood cancer, and all her friends just sort of were shocked. And yeah, you know, like
I think you handled it fine. I think I'd much rather that she view it as normal and was able to articulate it, rather than felt like it was something to be ashamed of, or that she didn't know about it and find out later as a shock. I think that all sounds very good.
yeah, and also dealing with different types of children. So my son and my daughter are like chalk and cheese, and one child has autism, so I have to like be a bit careful with that. And one did not want me to get in a wheelchair if I couldn't go around the shops. He just thought it was embarrassing. Whereas the other one was like, oh, that's cool. We can just race around, you know. So that there's different levels there too. And in terms of hospital stays, I found one would be more sensitive and just cry a lot, and the other one would be, oh no, this is good for mummy. They're gonna, you know, thin her blood out a bit, put her on an apheresis machine, take out what's wrong, and you know, that type of stuff. Trying to keep it age appropriate, I found was difficult, like in terms of how do I explain to all different ranges of ages a stem cell transplant. So I kind of said, well, if mummy finds a match, there's someone out there that might have a match. They'll just, you know, my bone marrow, like my garden is all full of weeds. So they'll sort of get rid of all those weeds, and then they'll put in these new seeds and grow a whole new working garden.
That's a very good analogy. I love it.
I think for those that are interested in learning more about that parent-child communication, we did have a previous webinar on talking to children about blood cancer, which is fantastic and really expands on a lot of the wonderful things you've shared. We've had so many questions. Charlotte has covered a lot of information. We can't get to anything more today. We're all full up to the brim with luscious, wonderful news. So I'm going to hand back to Linda to finish off the session.
Thanks, Jen, and thanks to Charlotte and Sharon, sincerely for just an incredibly insightful, warm and compassionate discussion on a topic that is so incredibly needed. And we could just spend so much more time. I think we've just touched the tip of the iceberg, haven't we, really? We could have follow-up session 2, 3, 4, 5 and 10. And Jen, and for everyone in the audience, I have also shared that parenting a child or talking to a child or children with blood cancer in the chat for those of you who had some questions around that. I'd also like to take this opportunity to thank the audience. We really do hope that today's session has provided you with some valuable insights and some tips to support your emotional health and well-being, and ultimately those relationships that are of greatest importance to you. If you have any further questions, please call us on 1800-620-420, or you can email us here at support@leukemia.org.au, and our lovely our supportive care navigators can talk to you and respond to your needs. In a mental health crisis, please call the National Crisis Support Lines, which will be shared in the chat in just a moment. The webinar has been recorded and will be emailed to you in about a week for those who have registered, or you'll be able to also find it on our website. So as we wrap up, let's remember that blood cancer affects not only our body, but it also affects our heads, our hearts, and the connections that sustain us. Reaching out, listening, and sharing honestly can make a real difference for ourselves and for those that we care about. Thank you for being part of this conversation today and for bringing such compassion and openness. Go well. Thank you. Bye.